And I thank PACE Hospital team, Dr. Govind Verma and Dr. Fani for giving me this opportunity. ERCP and liver, somehow I always joke with my colleagues saying that I generally try to stay away from the liver because I try to refer all the liver cases to my transplant hepatology team. The only exception is during endoscopic ultrasound and ERCP I stay close to the liver. So finally, I would start thanking my mentors, PGI and Dr. Rakesh Kochar, for because of whom I am here right now. ERCP was introduced somewhere in around 1960s, and first pediatric procedures were done somewhere around 1980s. And now ERCP has become a very commonly performed procedure, endoscopic procedure, even in the children. I'll not go into the details, but pediatric ERCP, is it really different from the adult ERCP? The method remains the same, but the procedure is different. Why is it so? Because the ERCP scopes and accessories were actually designed for the adult patients. We extrapolated it and we are using for the pediatric patients. So difficulties were encountered and pediatric ERCP scopes got designed. So scopes and accessories couldn't fit all the patients. So it took a while for the scopes to be redesigned for pediatrics. And the second thing was expertise. It does matter a lot. And most of these pediatric ERCPs were done by experts in the high volume adult centers. And pediatric gastro subspecialty took a while for it to evolve. So we have a different experience right now. Now, coming to the actual procedure, is it really different? The antrum and duodenum in infants, especially in the infants, is quite at a short distance from the EG junction. So to approach it, unlike in the adults, we do not have to create a great loop around the greater curvature. So especially with the side wing duodenoscope, we have to be pretty careful at reaching the pylorus because we would not be visualizing it directly. Now, the other difficulty in pediatric ERCPs is the short position. In an adult patient, you would directly go into the duodenum and withdraw it and to make it into the short position. Whereas in the infant, it would be difficult because you would be falling back into the pylorus. So occasionally, there is no alternative but to do the ERCP in the long position. So this is just a depiction of different positions of the ERCP scope. This has been picked up from a pediatric ERCP paper. Now, in an adult, we voluntarily create such positions to achieve the papillary axis. Whereas in pediatric patients, we may have to be forced to use these positions even though it is not the optimal position for the ampulla. Now, is it really safe? Is pediatric really safe? Can we do it? Now, I'll give you a few publications which say that yes, it is really safe, both from the real world data, from offhand experience of the experts, as well as from publications. The numbers which I have mentioned are the total number of procedures which have been done in different number of patients. So this is one publication of 856 ERCPs done, which says that it is pretty safe. 289 and 221, this 221 ERCPs are for pancreatic disease from Asian Institute paper. 429 procedures, it's really safe and efficacious in this Journal of Pediatric Gastroenterology and Nutrition. 54, 244, 65, 24, 703. This is a systematic review which has told that it is really safe and the total complications are comparable to that of the adults and it's not different. Now, coming to the third topic, is the room going to be something different? No, it is almost the same except that small changes. Like for example, the mouth bite might be bigger. However, it is not like a trismus or a limited jaw opening, so we might be able to use the adult mouth bites. Pediatric nasal cannulas, pediatric BP cuffs, pediatric pulse oximeter probes might be necessary. IV mechanized flow pumps might be needed. So these are some differences in the room which might be necessary. Fluoro-compatible table might be the same. Now, the next topic is the fluoroscope or the SIAM. So, children are at an increased risk of exposure to the ionizing radiation, which might cause some trouble to them. So, we should try to limit the radiation. The ESG and SBAN guidelines say that the radiosensitive organ should be protected. Now, fluoroscopy versus SIAM. Fluoroscopy obviously gives the lesser amount of radiation. However, the machine is bulky, the table is fixed, we may not be able to achieve the oblique view. Now, SIAM theoretically, even though more radiation, it is portable and most important, we can achieve an oblique imaging. For example, you want to look behind the ERCP scope. What do we do in an adult? We just push the scope or pull the scope. Here in a pediatric ERCP, we may not be able to do that, we might fall back. So we have to just change the SIAM. For that, SIAM might be useful in oblique imaging. Now, the other rules to limit the radiation damage to the pediatric patients is keep the the X-ray image intensifier, the image intensifier above the patient at the maximal distance, and the least amount of magnification should be used. Use collimators to focus exactly on the area, avoid the use of a grid, and most importantly, slower the pulse rate so that limit the amount of radiation. Now, this is how a pediatric ERCP or a neonatal ERCP would actually look like. Now, anesthesia, most of them are performed in the prone position. However, in a post-transplant or in a post-surgical situation, if it is demanding, we can do it in the supine position. And ESG and SFGAN guidelines say general anesthesia. However, in older children, we can consider deep sedation. Smaller size DT tubes, cuffed or non-cuffed pediatric veins and pediatric cannula should be ready with us. And the only small difficulty might be intubating it along with the ET tube in situ. Sometimes we may have to deflate if we are using a cuffed tube. Now, this is the most important topic of the whole presentation. What duodenoscopes do we use? This is just a pictorial representation to show what would be the size of the scope when we compare to the infant or neonate. This is an pediatric, the smaller one is the pediatric scope, that is the 160 series scope, which probably we are not using these days. And this is the different comparison of pediatric scope versus the adult scopes. So the pediatric duodenoscope from Olympus, which was available in the past and not available right now, is the PGF scope 160, which has got a diameter of 7.5 millimeters and a biopsy of channel of 2 millimeters. This is the pediatric ERCP scope which is available. Now, this is the standard Olympus recent one, 190 scope, which has got an outer diameter of 13.5 and a working channel of 4.2. Now, I'll go through the other scopes of other companies. Pentax, this has got two scopes. The adult one has got again 13.6 distal diameter, and a slim scope from Pentax is also available. However, it is not up to the tune of pediatric one. The distal diameter is only just 12.5 mm. Now, this is from the Fuji. Their diameter is 13.1. So, if you compare the adult scopes, Fuji has got the smallest one. This is an older data which was published elsewhere. So, this is not the actual representation of the present available scopes. Fuji has got the smallest diameter, 13.1 mm, and Pentax as well as Olympus have got 13.5 mm if we consider the adult duodenoscopes. Now, what does ASG say? Less than 10 kgs. Please use the pediatric duodenoscope, and more than 10 kgs, better is to use the standard adult duodenoscopes. Now, what is the problem with using a pediatric duodenoscope? The channel diameter is 2 millimeters. So, the problem is that the accessories, there are no functional tools to use for a 2 millimeter. Most of the devices which we need to use should be less than 5 French, which is practically difficult to get. There will be limitation to the access, there will be inadequate suction, we will not be able to use the elevator fully. Now, so does size really matter? Obviously, beyond 1 year, it doesn't really matter. So, beyond 1 year, try to use the adult scopes. Below 1 year or below 10 kgs, probably the pediatric duodenoscope should be used. Now, accessories, I'll just rush through a few accessories and the standard sizes. Generally, we don't have a look at these things because we commonly use for the adults. This is the Boston sphincterotomes, the True Tome, which is the smallest available sphincterotome, that is 3.9 French. 3.9 French would be approximately 1 to 1.3 millimeters. And this is the Clever Cut, which is again almost the same, of around 4.4 French, the biggest one. And this is from the Cook, which is again much bigger, which has a diameter of around 6 French, 5.4 to 6.6 French. Now, stone extraction balloons, can we use them? No, because they require a minimal diameter of 3.2. So, if we are using a pediatric scope, we can't use it. And the catheter itself is around 7 French. So, obviously, we will not be able to use it in pediatric and neonatal patients. Now, so pediatric ERCP experts routinely use 3 to 5 French tapered catheters and 0.18 wires and 5 French papillotomes and 3 to 5 French stents, most of which are available only on a special order. Standard stone extraction balloons cannot be used. We need to have some innovation, or we have to ask the vendor to get it done for us. Now, stents, we know the standard 7 French stent is a commonly one used, whereas in pediatric age group we need 3 to 5 French stents. Why that is important is the that's the CBD and the PD diameters in pediatrics, that is less than 1.2 and 2 mm. So that would be approximately around 5 French. Yeah. The last two slides, a brief role about the technician. Technician, we all know, plays 50% role in the success of ERCP even in adults. So the similar thing even in the pediatric age group also. Most importantly, they need to keep these things ready, the 025, 018 and the 3 French or 5 French distal tip catheters. Most important is that we may not be able to engage the ampulla with the standard sphincterotomes of the adult because they are around 6 or 7 French, whereas only 3 to 5 French will engage. So we will be using a wire-guided cannulation more frequently. So the technician really needs to be very good expert and he shouldn't push away because we will not be having enough amount of space to create a V or to use the traction techniques. Now lastly, the endoscopic expertise, only the ASG recommends a minimum of 200 ERCPs and 50 sphincterotomies to be done by the ERCPist if they have to do a pediatric ERCP. And probably the endoscopy should be quick and crisp in movement to avoid complication and to expedite the procedure. So, I would like to conclude with this saying that pediatric ERCP is pretty safe and comparable to adult ERCPs. Even though radiation is slightly more in C-arm, C-arm is better because it gives oblique imaging and it is more portable. Most of them would need intubation and general anesthesia, and we should be able to use a standard adult duodenoscope in majority of the children or infants above 10 kgs. Below, pediatric scopes are needed which are not available unfortunately. Accessories limitations are there. You need to have a good technician and endoscopic expertise to maximize the success rate and minimize the complications. Thank you.